Hello everyone. I've spent over 100 hours compiling questions and high-yield content for you to master and memorize by the time you finish your second NBME. I'm doing this because I want you to pass step 1. A quick disclaimer, the questions in this video are original, educational material that I've created. They're inspired by the style of board exams, but they're not taken from or affiliated with NBME, USMLE, or any official test bank. This content is for learning purposes only and does not replace the official study resources. If you find this helpful, please like and subscribe. By the time we finish, all of this is going to be filled up. This is everything you need to know by the time you finish NBME 27 in infinite scroll style, but we're going to start with DHT and 5-alpha reductase. So we have a 2-day-old infant that is brought for evaluation of ambiguous genitalia. Pregnancy and delivery were uncomplicated. Physical exam shows a phallus with urethra opening at the base and partially fused labioscrotal folds. So ambiguous genitalia. But DHT levels are significantly reduced. Which enzyme is most likely responsible? The answer is going to be 5-alpha reductase. So this infant has normal testosterone production, which supports the Wolffian duct development, but you have defective conversion to DHT, and that leads to underdeveloped external male genitalia despite internal structures that are present. You don't see external, but you do see internal. That's classic for 5-alpha reductase deficiency. Internally, we have the anti-Müllerian hormone from the Sertoli cells that suppresses the Müllerian structures. And because of that, we don't have the female internal manifestations, but rather the male, because of that Sertoli expression of anti-Müllerian hormone, hence the absence of the female internal ducts. Now, why is the answer not aromatase? It's important to know why the other ones are wrong. So aromatase, that's a key enzyme in estrogen synthesis, and deficiency would not explain ambiguous genitalia with low DHT. B, 17-alpha hydroxylase, that would lead to low androgens and ambiguous genitalia, but it also causes hypertension and underdeveloped internal male structures. Why is not 21 hydroxylase? Well, that would cause excess mineralocorticoids and androgen production, typically virilization with hypertension, not under-virilization. And so it's important to know that some newborns with XY can be born looking externally female. And it happens when the body can't properly convert testosterone into a more potent form called dihydrotestosterone, or DHT. And DHT is what sculpts the external male genitalia. Without it, the baby forms normal male internal ducts from testosterone action. But the outside looks ambiguous, or even female at birth. So on test day, you'll see a newborn boy, normal testes, no uterus, but ambiguous genitalia. The testosterone levels will be normal, but the DHT is low, and that points to the deficiency that causes the DHT, which is 5-alpha reductase. And so really look out for the normal internal male structures, which means testosterone is working. That's super key for this question. And then if you have ambiguous external genitalia, that means DHT is not. So then you put those clues together and you go, boom, 5-alpha reductase deficiency, and that's all there is to it. For the next question, we need to talk about ADEK. So we have a 22-year-old man with a history of Abetalipoproteinemia that is evaluated with progressive difficulty with balance over the last 4 months. He reports frequent falls and a new tingling sensation in his feet. He has had chronic diarrhea since childhood, and on exam, he is alert and oriented, but shows reduced vibration sense in both feet, bilateral lower limb hyporeflexia, and wide-based gait. Labs show normal complete blood count without macrocytosis. Peripheral smear demonstrates numerous acanthocytes, also known as spur cells, but they're red blood cells with a distinctive spiculated appearance, have irregularly spaced thorny projections of varying sides. And spiculated just means it's like a mass with a sharp radiating lines or spicules that extend from the borders, kind of like that. And so which of the following vitamin deficiencies explains this finding? Now, it was nice of them to just flat out say it's a vitamin deficiency, but the neuro-associated vitamin deficiency and the gait problems would be vitamin E, and that's our answer. So they have ABL, Abetalipoproteinemia. It's a rare inherited disorder that's characterized by the body's inability to produce or transport lipoproteins that contain apolipoprotein B. And so you get malabsorption of fats and fat-soluble vitamins. And that's why we talked about ADEK, because they're all at risk. So E protects the neuronal and erythrocyte membranes from oxidative damage. And so you lack it, then you'll get axonal degeneration. And so you'll present with ataxia, hyporeflexia, cytosis, which again is the spiky red blood cells, uneven thorn-like projections. And you get that without the megaloblastic changes that are seen in B12. Because you might be saying, okay, why is this not B12? Well, B12, you'd have megaloblastic changes in the red blood cells. And here you don't. You just see like ataxia and acanthocytosis. Why is it not? Vitamin A deficiency causes night blindness, keratinization problems. You have the Biddett spots on the conjunctiva, also immune dysfunction. It would not cause posterior column demyelination or spinocerebral dysfunction. That's why it's not A. Why is it not vitamin B1? Well, B1 would be Wernicke-Korsakoff. That's a thiamine deficiency that causes thalamoplasia, which is paralysis of the muscles within the surrounding eye, confusion, cardiomyopathy, and not sensory ataxia. Totally different. Also, we got to focus on fat-soluble vitamins. Okay, what about vitamin D? So vitamin D, you'd see bone pain and rickets. A deficiency leads to osteomalacia or rickets, not spinocerebral dysfunction, and that's why it's not D. The answer is indeed E for this question. Another answer that they might give you is like niacin, for instance, and that would be your pellagra. So dermatitis, diarrhea, dementia, and death, the classic Ds, pellagra. And that's just a deficiency disease that's caused by a lack of nicotinic acid or its precursor tryptophan in the diet. It's characterized by dermatitis, diarrhea, mental disturbances. And usually you'll have like an overdependency on corn as a staple food is how you'll see it. But it's not niacin, that's pellagra. Dermatitis, diarrhea is really what you'd see for niacin deficiencies. And so on step 1, this might come up and they'll say, we got a young adult who keeps tripping and they can't feel their feet very well. And the labs are normal, but the childhood history is full of greasy stools, maybe cystic fibrosis, fat malabsorption. And one of those vitamins, vitamin E, acts as a shield against free radicals. And when that shield is gone, the neurons in the posterior columns and the spinocerebral tracts will start to degenerate. And that leads to ataxia, hyporeflexia, and also vibration sense is lost. And so you see malabsorption, progressive neurological dysfunction. You shouldn't just think B12 automatically. Though that's a good intuition, you should be thinking of E. B12 deficiency would be seen with megaloblastic anemia, and these guys aren't. Acanthocytosis is what they're seen with. Acanthocytosis for E, B12, megaloblastic. All right, awesome. Moving on. So for 3, I want to bring your attention to this image. I think it's a really good one. This is like your normal left ventricular geometry. You can see your sarcomeres, they're kind of just normal here. If we add in parallel, then we get hypertrophy, concentric, and then eccentric, you have increased ventricular volume. And that's going to become important for this question. So we have a 48-year-old man with poorly controlled hypertension and long-standing type 2 diabetes presenting with evaluation of dyspnea. Blood pressure is 165, so super high, and he has a normal S1 and S2 without murmurs. Ejection fraction of 55%. There are no regional wall motion abnormalities. What best describes the cellular adaptation in his left ventricle? Okay, so this patient has concentric left ventricular hypertrophy from long-standing hypertension. So to handle the high afterload, cardiomyocytes add sarcomeres in parallel. They're not adding them in series so that it would expand, they're adding them in parallel so they can contract. And that thickens each cell and it increases the contractile force, but it's at the cost of compliance. Our answer is going to be the addition in parallel. Why is not A, loss of myofibrils and collagen deposition? Well, loss of myofibrils and then collagen deposition would be kind of a clue that we're talking about scar tissue. And that's seen after infarctions, but it's not adaptive hypertrophy. Why is it not E, neutrophilic infiltration between cardiomyocytes? So neutrophil infiltration would be seen with an acute MI. We have inflammatory infiltrate after necrosis, and that's not going to be a chronic adaptation. So the high yield thing is that your heart can remodel its muscle fibers in response to stress. And chronic high blood pressure, the left ventricle must push against higher resistance every single beat. And so to adapt, each cardiac muscle cell will stack more sarcomeres side by side, and that thickens the ventricle wall and it gives you concentric with if you know Spanish, with centric hypertrophy. And on an ECG, you might see huge voltage, like a tall R wave, S in your V2. And on echo, the ventricle looks thick, but its cavity size is normal. And it's not scar tissue, because that's a response to volume overload. It's parallel sarcomere growth. Now, I mentioned amyloidosis and Fabry, and so I just want to clear that confusion before we move on to the next question, in case you see that on test day. Amyloidosis has some really buzzy things associated with it. It's apple green bifringence with a Congo red stain, and you have deposition of misfolded protein between the myocytes. That's your amyloidosis. And the mechanism there is just misfolded protein. So you have light chains or transferrin in senile systemic amyloidosis, and that accumulates in the extracellular space, and it stiffens the myocardium and impairs diastolic filling. And that leads to amyloidosis, leads to restrictive cardiomyopathy. And that can be in multiple organs, all right? Like your kidneys, so it's nephrotic syndrome, or your liver, or your GI tract, or your peripheral nerves. And in the heart, you'll see thickened walls without the expected increase of voltage. So it's low voltage, despite hypertrophy on the echo, is going to be a classic sign for your amyloidosis, restrictive low voltage despite those changes. And then the other one I mentioned, and anytime I mention something, I just want to make sure that I cover it and kind of close any loose ends, is Fabry. And that's an X-linked lysosomal storage disease. It's a deficiency in A-galactosidase A, is how I like to remember it. So it's alpha-galactosidase A, but I like to think A-galactosidase A, which helps me think of Fabry. It's accumulation of your ceramide trihexycide in the tissues. And if you're interested in that mechanism, it's the glycosphingolipid buildup within the myocytes. And you get vascular endothelium and other cells, so it's progressive organ dysfunction. And it leads to hypertrophic or restrictive cardiomyopathy. So hypertrophic or restrictive cardiomyopathy is seen in Fabry's and amyloidosis. Early on, you could see angiokeratomas, that's like the tiny dark red lesions, and burning in the hands and the feet. And then later you can see renal failure and cerebrovascular disease and cardiac involvement. So left ventricular hypertrophy and conduction abnormalities. Okay, don't want to get too much into the weeds about that answer, but now you know like everything there is to know about all of these answer choices. Okay, for question 4, we have a 63-year-old man with poorly controlled diabetes presenting with 1-day history of rapidly spreading redness and pain over his right forearm after nicking it while shaving. So he has fever, chills, malaise, and on exam, his temperature is 38.7, heart rate is 105. His forearm shows diffuse erythema and indistinct margins, warm, tender. So there's no purulent drainage. Blood cultures are drawn and gram stain shows gram-positive cocci and chains. What's the most likely pathogen? Strep pyogenes. So we have acute non-purulent. Cellulitis is just a fancy word for saying the inflammation of subcutaneous connective tissue. And you got systemic signs, so gram-positive cocci and chains definitely points you to your group A. Beta hemolytic streptococcus, that's strep pyogenes, and that's a leading cause of cellulitis that spreads via your tissue planes. Why is it not Pseudomonas? So Pseudomonas, that's a water exposure bug, often causes folliculitis, and that's just inflammation of your hair follicles. Thema gangreosum, and that's not classic cellulitis, so Pseudomonas is just different, totally different presentation. And S. epidermidis, that's going to be prosthetic infections, so you have a low virulence skin flora and not massive cellulitis. So how this might present on test day, they'll give you a dude who's got diabetes and he's got a small cut on his arm. And then within 1 day, his skin is like bright red and it's hot and it's tender. And he's got a fever. And then on gram stain, they'll give you gram-positive cocci and chains. Now, why is it not Staph aureus? That's often going to form abscesses and pus. Group A strep causes non-purulent cellulitis. And it secretes enzymes like hyaluronidase and streptokinase, and that will break down the tissue barriers and it lets the infection race along the tissue plane. And some of you guys might be thinking, okay, Group A strep versus Group B, what does all that mean? Group A strep mostly affects kids and adults. Causes strep throat, skin infection, cellulitis, impetigo, scarlet fever, rheumatic fever. Also, the key test for Group A strep is going to be very different. So think like adults, throat, skin problems. And then Group B strep mostly affects newborn babies. So baby infections like meningitis, pneumonia, sepsis. And these guys are resistant to this test. So B stands for babies, A stands for adults. That's how I like to think of it. A is more skin, throat infections, and B is for the babies. So serious newborn infections. All right, for this next one, we have a 33-year-old man unresponsive in his car. Empty morphine bottle nearby. Arterial blood gas shows a pH of 7.28, PaCO2 at 60, PO2 at 85. Which factor explains his increased cerebral blood flow? So it's going to be his elevated PaCO2. And the reason why is your cerebral vessels respond strongly to arterial CO2 rises, like cerebral dilation, and cerebral blood flow is kind of independent of that across your wide range. Decreased PO2, so hypocapnia would cause vasoconstriction. So if there's less of this, then you're going to constrict. And if there's more of that, then you're going to dilate. Increased heart rate would be indirect. It doesn't really control your blood flow, your cerebral blood flow, at least not to the extent of just carbon dioxide's presence. And acidosis is not the driver, it's CO2. So your brain's blood flow, what you need to know is that it changes within minutes based on the CO2 level. When you hypoventilate, like in a narcotic overdose like this dude had, your CO2 builds up in the blood and that diffuses to the brain and it generates hydrogen ions and it relaxes the smooth muscle and the cerebral arteries. So you get vasodilation. All right, next we have a 10-month-old infant receiving routine immunization series designed to prevent meningitis from encapsulated bacterium. The vaccine contains capsular polysaccharides chemically linked to diphtheria toxin to enhance immunogenicity. Which best describes the composition of this vaccine? All right, so we have Hemophilus influenza type B vaccine, and this is going to be a conjugated capsular polysaccharide vaccine. And it links the polysaccharide to a protein carrier like the diphtheria toxoid, and it will convert the response from a T-dependent one. So it'll convert this response into a T-dependent response because it's going to link the polysaccharide to a protein carrier like diphtheria toxoid, and that produces high affinity antibodies in memory. And there are several different types of vaccines, and I think I may have gone over this before. There's live attenuated, that's like oral typhoid, BCG, that's used as against, the mechanism is kind of different here. You use weakened organisms in the live attenuated. So it's not A. Now B is the correct answer. C is not right. That's the outer membrane protein. So it's under development, not the basis for your Hemophilus influenza vaccine. Oh, I said B, I meant D. Okay, so let's just make this super duper clear. Hemophilus influenza type B is a bacterium with a capsule that's made of sugar. Of course, we got to use the fancy word polysaccharide. And that capsule helps the bacterium avoid being eaten by immune cells. So if a baby gets infected, it can cause meningitis, pneumonia, and sepsis. Now, why is making the vaccine tricky in babies? Well, babies younger than 2 years old do not respond well to plain sugar antigens like those capsules. Their immune systems, specifically their T cells, don't get activated properly by pure polysaccharide. And so a response without the T cell help is called a T cell independent mechanism. It makes only short-lived IgM antibodies and has no memory. And so the solution then, some scientists will just link that conjugate polysaccharide to a protein that T cells recognize easily. Like an example of this is diphtheria toxoid. And so when the immune system sees this combo, the protein part gets presented to T helper cells. And then the T helper cells activate the B cells, and the B cells switch to making IgG from memory cells. And that makes a response T cell dependent. It's strong and long-lasting protection. And so this question is really just getting at, hey, what is inside of this vaccine? What's inside of Hemophilus influenza type B vaccine? It's not going to be a live bacterium, so A is wrong. That's like when you put like weakened stuff in the bacteria and it just fights it off. It's not the whole killed bacteria. It is a conjugated capsular polysaccharide. That's the sugar capsule that links to a protein like diphtheria toxoid to make it immunogenic. And so the key point here is the HIB vaccine is a capsular polysaccharide and protein carrier, and it has a strong T cell dependent immunity that works even in infants. And that's why the correct answer is conjugated capsular polysaccharide. For our next question, we have a 30-year-old man with untreated HIV infection. He has a CD4 count, and he presents with 3 weeks of profuse watery diarrhea. We kind of already know what this is, but they also tell us that he has dual microscopy revealing numerous spherical organisms clustered along the intestinal border that has acid-fast stains. So they're really just giving you everything you could possibly ever want here to diagnose this as crypto. And some of you guys are asking, hey, what is crypto? But not in the fun 2012 way where you're all going to become millionaires. Crypto, rather in the doctor way, where you're going to slave the next 10 years of your life to learn redundant medical content. Cryptosporidium, Parvum, is a tiny protozoan that's often seen in patients with advanced AIDS. And it lives in the surface of intestinal cells, and it releases a tough little oocyte that stains red on acid-fast staining. So in healthy people, the illness is self-limited. But if you have a low CD4 count, I think this dude had a 50, right? Then the infection becomes chronic and it causes relentless watery diarrhea and dehydration. So on exams, you'll see a person with AIDS, weight loss, acid-fast oocytes. It's definitely going to be like a dead giveaway for Cryptosporidium. And so the key is to restore immune function with antiretroviral therapy and support fluids. So that's why the answer here is crypto. I don't want to spend too much time on the other answers, but I will say, B. C. diff, that's a pseudomembrane toxin-mediated colitis with leukocytes, not acid-fast at all. So it's definitely not C. diff because that's going to come up a lot. And then maybe strongyloides, that's going to be larvae in the stool. So it's a helminthic infection with eosinophilia, not protozoa acid-fast organisms. And you guys might be saying, okay, what's a protozoa? Basically, it's a single-celled eukaryocyte. It could either be free-living or parasitic. And it feeds on organic matter like other microorganisms or organic debris. So they're basically one-celled animals is how you think of those guys. And the helminth, that's just a parasitic worm. Okay, so that's 7. Moving on to 8. So here we have a 62-year-old woman presenting with intermittent vaginal spotting for 2 months. Menarche at age 11. She had 2 pregnancies in her 20s, and she's become on long-term estrogen-only hormone replacement therapy since menopause at age 50. BMI is 32. Endometrial biopsy shows atypical glandular proliferation consistent with endometrial carcinoma. What's the strongest predisposing factor? The answer is going to be long-term estrogen-only therapy. And so endometrial cancer risk is driven by excess estrogen that's unopposed by progesterone. And so this person had a decade-long estrogen-only therapy that provides continuous proliferation, just like keep growing, grow, signaling to the endometrium, and that makes it the strongest risk factor. Multiparity, that's just a woman who has had 2 or more pregnancies that have resulted in a viable birth. That is protective. You have fewer ovulatory cycles during pregnancy, and so you lower the risk of endometrial cancer. Smoking is actually not a risk factor for endometrial cancer. It's associated more with squamous malignancies. Alcohol is linked with breast and liver. So if you do see alcohol, because really you might see this on test day, then you should be thinking of breast and liver, but not endometrial. And then late menopause, that actually increases lifetime estrogen exposure, but it's a lot less impactful than just scarfing down estrogen. So postmenopausal bleeding is never, ever normal. In many cases, it's the first clue to endometrial cancer. And what fuels that is almost always excess estrogen. And estrogen stimulates the endometrial growth, but without progesterone to counterbalance. And so the tissue keeps proliferating unchecked. And so over time, this leads to hyperplasia and eventually carcinoma. And so in this patient, we get a long-term estrogen therapy. And so when estrogen is given without progesterone, the endometrium is left unopposed. And then you get like a huge risk of developing cancer. And remember that progesterone has this balancing effect. It stabilizes and limits endometrial growth. And that's why you need to give it with estrogen. So progesterone normally counteracts the estrogen by promoting the secretory changes and periodic shedding. And when that's absent, like in estrogen-only therapy or in states with excessive estrogen, like obesity, for instance, I think she had like a BMI of 32, right? Chronic anovulation or early menarche and late menopause, then the endometrium remains in a constant proliferative risk state. And so that'll just supercharge or just super increase your cancer risk. So you should always add a progestin to the estrogen replacement in a woman with an intact uterus to prevent endometrial hyperplasia and carcinoma. So our next question, we have a 4-year-old boy who is brought to the emergency department after ingesting a unknown quantity of his father's type 2 diabetic medication. He is asymptomatic on arrival, and labs drawn 6 hours later show a high anion gap metabolic acidosis. So type 2, okay, we're already thinking a couple of things. It's going to be B, increased lactic acid concentration, toxicity that impairs mitochondrial oxidative phosphorylation, and gluconeogenesis. Hydrogenase metformin, diabetes type 2. And that will cause a lactate accumulation and lactic acidosis. And it's a rare, but it's a dangerous complication that you have to know about even without hypoglycemia. You can see this. Okay, why is it not like lower potassium? Well, that would be seen in insulin overdose, not metformin. Why not low glucose? Metformin does not actually cause hypoglycemia. It's insulin sparing. Why not your elevated ASTs, your liver enzymes? And that's linked to like hepatotoxic drugs, not metformin. What about increased creatinine? Why is not increased creatinine? That's seen in acute kidney injury. While renal dysfunction increases the risk, it's not the primary abnormality from the ingestion. So yeah, diabetes drugs like metformin can lead to a life-threatening acid pileup. And metformin is a NSAID, which basically works by reducing glucose production in the liver and increasing the body's sensitivity to insulin. And so it normally helps with the blood sugar safety. But you have overdose and it'll block the mitochondrial respiration and it prevents the liver from using lactate for gluconeogenesis. And so that lactate will pile up in the blood and it causes dangerous high anion gap metabolic acidosis. Okay, but why does metformin cause lactic acidosis, of all things? Well, metformin's main action is to inhibit the mitochondrial oxidative phosphorylation and also suppress hepatic gluconeogenesis. That's like its whole goal, its whole shtick. And so normally the liver will take lactate, which is a byproduct of the anaerobic glycolysis pathway, and it uses it as a substrate to make glucose through gluconeogenesis. So lactic acid is a byproduct of anaerobic glycolysis. And now let's make that lactic acid into glucose. Yay, Genesis, we love the body, yay. But when metformin is present in excess, then the pyruvate from the glycolysis cannot enter the mitochondria efficiently. And so instead of being shunted into the TCA cycle like it should be, because you get the pyruvate over here, you guys have all drawn this for the MCAT, you get the pyruvate over here, it shunts on over to the mitochondria. But now pyruvate is actually just going to be converted into lactate. And so simultaneously, the liver's ability to clear the lactate is going to be reduced. And so it's just this horrible situation where the net effect is lactate builds up in the bloodstream and the high anion gap metabolic acidosis will prevail. And another high yield thing about this low potassium is that hypokalemia, which is low potassium, is classically seen in insulin overdose. And that's the reason why is because insulin activates your sodium, potassium, ATPase pumps, gets those things going. And that will drive the potassium in from the extracellular space into the cells. And that drops the serum potassium. And so there's this common confusion. I don't think it's taught very well, but whenever we're saying like, okay, there's a drop in potassium, what we're saying is it went into the cells from the extracellular space. And so metformin does not cause excess insulin increase stuff. And so you don't get any shifting of potassium. And so here's just some little notes that I took while I was talking, and now on to 10. So before we dive into this question, which is often missed, I want to teach some basic stuff. As you know, iron is required for heme synthesis. And so if you don't have enough, then the red blood cell precursors keep dividing to reach the target concentration. And so you get small, pale cells. So we need that iron or else we get the small, pale cells. And if you're on a vegetarian or a vegan diet, you have a low intake of heme iron. And so your iron stores go down if you're just pure vegetarian vegan. And so you get chronic blood loss, menorrhagia, or GI bleeding. And that can also lead to iron deficiency through that negative iron balance. And the reason why we have all these problems is because iron is not produced endogenously. It has to be absorbed from the diet or recycled from senescent red blood cells. You know, senescent is just a fancy word for saying like old red blood cells. Mature ones, let's say. They've been around for a while. They got iron to give. And so the pathophys is that you have a low heme intake, and so you have declining iron stores in ferritin, and you have inadequate iron for your production. And so the red blood cell precursors undergo extra divisions to reach the minimal threshold. You need to have a certain threshold of hemoglobin, or else you're just screwed. And so you get microcytic small and hypochromic pale erythrocytes with normal shape. And so your peripheral smear shows elongated, central pallor, reduced MCV. That's the reason why iron deficiency has the reduced MCV. Hopefully that made sense. I'm trying to explain this in the simplest way I can. If you guys are liking this stuff, please like and subscribe, or just tell me how I can improve, putting all this work in for you guys. And so some key features that you might see in a patient like this one, you have a hemocrit that's low, so you have normal B12, and a peripheral smear that has hypochromic microcytes in normal shape, and a treatment is going to be oral or IV iron. You just got to give them that iron. Now let's do the question. 42-year-old man presents to the clinic because of his progressive fatigue and reduced exercise tolerance the past 4 months. He works as a marathon trainer and runs 20 to 30 miles per week. Relatable, just kidding. He notes that he has been taking up large amounts of over-the-counter ibuprofen and knee pain. He has no significant medical history and eats a balanced diet that includes fish, chicken, and vegetables. Examination shows pale conjunctiva, but no hepatosplenomegaly. Lab shows some interesting things. We got our heme is low, and we got mean corpuscular volume is low, so microcytic anemia, and ferritin is decreased, but is normal B12. And so peripheral smear is most likely to show which of the following features. Okay, so by now we probably can tell that the answer is going to be pale, small, and normal shaped. But we still need to know why. And so this dude is a runner, and what is he using chronically? He's using NSAIDs, okay, David Goggins. And that can cause occult gastrointestinal bleeding. Ding, ding. That's the mechanism that you need to know. And that leads to iron deficiency anemia, and the iron loss reduces the hemoglobin production, and it results in microcytic, so small, hypochromic, pale, red cells, and a normal shape on the smear. Okay, why is it not this guy a target cells? So target cells is seen in thalassemias and liver disease, not iron deficiencies. What about macrovalocytes? That's seen in B12 or folate deficiency, which is not this case, as B12 is normal. And so our answer is C, hypersegmented neutrophils. That's seen in megaloblastic anemia, schistiocytes. That's going to be fragmented from microangiopathic processes. So marathon runner, ibuprofen daily for knee pain. Dude, you're going to be bleeding from your gut in no time. And so pale, small cell, just that blood loss, you're trying to compensate, but you don't have enough iron because you can't make it endogenously. And so that's the reason why. The answer is C. Next question, we have a 31-year-old man hospitalized, collapsing, high fever, and confusion. He's been injecting, and infection of which valve most likely explains it. It's going to be the tricuspid. And this one's pretty easy. That's why I'm going quickly. It's the right-sided endocarditis is typical for IV drug users. And so you have vegetations of the tricuspid valve are going to lead to tricuspid regurgitation. That's a holosystolic murmur at the left lower sternal border. And also you can have JVD with that. And it's a septic emboli that can shower the lungs there. So intravenous drug usage, Staphylococcus aureus. That's going to be your classic setup for right-sided infective endocarditis. And I love this one because it makes so much sense. It's like the heart. That's the first part of the heart. So try before you buy, tricuspid, mitral. So the tricuspid regurgitation is going to be a result of this. So the vegetations break off the tricuspid valve and it lodges into the pulmonary arteries, and that can cause multifocal cavitary opacities. And also you see JVD, right? Because it's like your right-hearted sign. So JVD, hepatomegaly, regurgitant blood flow, all that stuff you're going to be seeing. And that's because of the non-sterile IV infections causing bacteremia. The pathogens adhere to the cardial surface of the tricuspid valve and it causes vegetations to occur. And then you get the holosystolic murmur. Here we got a question and an explanation. I'm going to zoom in. 68-year-old man comes to the clinic because of worsening back pain and recurrent infections the last 4 months. He's got some unintentional weight loss. Exam shows pallor and mild splenomegaly. Normocytic anemia, hypercalcemia, and creatinine of 1.8. And we got a sharp monoclonal spike. What does that mean? Well, which malignancy is this? It's going to be B, lymphocyte neoplasia. Here's our explanation. A monoclonal end spike means the single plasma cell clone is secreting immunoglobulin. And since our plasma cells are differentiated B lymphocytes, it's going to be B lymphocyte neoplasia, most classically multiple myeloma. Okay, so it's not going to be your T lymphocyte neoplasia because the T cells don't actually make immunoglobulin, so there's not going to be an M spike there. Chronic myelogenous leukemia, so that's CML. The myeloid lineage would have your Philadelphia chromosome, not your plasma cells. A leukomoid reaction would have reactive leukocytosis, and you wouldn't see monoclonal proteins. And AML, that's not B cells at all, that's your myelogenous precursors. So this is definitely B cells. So we need to know what on earth an M spike is to answer this question. It's a sharp peak that's seen on the serum protein electrophoresis in the gamma region. And it means a single clone of plasma cells or B-derived cells is making a huge amount of one type of immunoglobulin, or at least part of it. And so normal people have many clones making many antibody types, and so the graph is always going to be smooth. But an M spike means that one is overproducing. So it's a monoclonal gammopathy. And so which cells make the immunoglobulin? So B cells mature into plasma cells. We got to know this too. And plasma cells secrete immunoglobulins, which are antibodies. And if a single plasma cell clone becomes malignant, then you get a massive production of one antibody, and that's an M spike. And so the most classic disease with an M spike is multiple myeloma. It's a plasma cell, which is usually a B lymphocyte lineage cancer. And the bone marrow is packed with clonal plasma cells in multiple myeloma. So we have multiple myeloma, and here's our bone marrow, and it's packed with clonal plasma cells, and they're overproducing one antibody type, so it could be like an IgG or IgA are the most common ones. And then you'll see an M spike on electrophoresis, and it's really important to know these associations are going to be bone pain, lytic lesions, anemia, hypercalcemia, renal dysfunction, and sometimes hepatosplenomegaly. So for this one, you really just need to know the basics where B cells are a type of lymphocyte, and the lymphocyte is just like a white blood cell, right? And they develop in the bone marrow, and that's why they're called B cells. And each B cell is born with the ability to recognize one specific antigen through its B cell receptor, BCR, which is essentially a membrane-bound antibody. And so what happens when a B cell meets an antigen? The B cell binds the antigen with its receptor, And usually it needs help from the helper T cells, which are like the CD4 positive cells that recognize the same antigen and release cytokines. And once it's activated, that B cell begins to proliferate. And after activation, the B cells can then become plasma cells. And these are antibody factories. They secrete large amounts of antibodies, which are immunoglobulins. There's no difference there. Globulins are just any class of proteins that are present in the serum or the cells of the immune system. And then each plasma cell just makes one type of antibody that matches the BCR. And so antibodies will circulate, neutralize, opsonize, and mark pathogens for destruction. And you also have, your memory B cells. And these guys are the long-lived memory cells. And they don't secrete antibody right away. They just remember. They never forget. And so if the same pathogen shows up again, then they will rapidly reactivate and make new plasma cells. And so in a healthy person, many B cells get activated over time, and you have polyclonal antibodies in the serum and many shapes on electrophoresis. There's not just like a single peak. But in multiple myeloma, you have a single B cell clone that becomes malignant, and it turns many identical plasma cells. And they all secrete one identical antibody. And so the serum electrophoresis will show a monoclonal spike that's an M spike in the gamma region. So B cells are antigen recognizers and decision makers. Plasma cells are antibody producing. And then your memory B cells are long-term surveillance. Okay, that's how all of this works. And that's how multiple myeloma works. Moving on in the world. Okay, so here we have a team of researchers that are developing this hormone called factor Y. It's isolated from a patient with an unusual pituitary adenoma. And to study its target tissue, they incubate radioactively labeled factor Y with isolated hepatocytes. And within minutes, we see the JAK-STAT pathway is detected. And this leads to an increased synthesis of acute phase proteins. When cells are examined under electron microscopy, the radioactive signal is localized exclusively to the outer cell surface and does not enter the cytoplasm or nucleus. Which of the following known hormones most closely resembles factor Y in its mechanism of action? So when these guys add factor Y to the liver cells, then they see two things happen. The signaling stayed on the outside of the cell. So here's our cell, and the signaling happened here. And this worked within minutes using the JAK-STAT pathway. That's all we know, but that's kind of enough. That means factor Y acts through a receptor on the cell surface. It does not go into the cell. And you should recognize this is how growth hormones work. What we have is a protein hormone. It's too big and water soluble to cross the cell membrane, and so it attaches to a special receptor that's sticking outside of the cell, which then triggers and signals stuff on the inside. So other hormones, for instance, if we had like cortisol, that just goes straight through and affect transcription. Estradiol, aldosterone, thyroid hormones, those are all lipophilic, and so they easily slip through that cell membrane, because remember, you need to be lipophilic to be able to just go on through, straight to the receptors inside and straight to the nucleus. And those take longer because they actually change the gene transcription. And so factor Y is acting like a growth hormone, simply. That's how it's acting. It's not cortisol, right? Because that's a steroid and it diffuses straight through to the intracellular receptors. It's not estradiol, that's a steroid as well. And aldosterone, it's got its receptors on the cytosol and it acts as a transcription factor. And thyroxine enters the cells in the nucleus and it binds thyroid hormone to the receptor. And you might be wondering, okay, well, that's cool. What are some other examples of hormones that act on the cell surface and stay outside? Well, you have prolactin, but also insulin binds to receptor tyrosine kinase on the membrane to drive the glucose uptake. Also glucagon that binds to a G protein coupled receptor. So that's another example of like a cell surface. Epinephrine, adrenaline also uses a G protein coupled receptor. Parathyroid hormone works in the G protein coupled receptors. And the ones that go intracellularly, these are usually lipid soluble like steroids or thyroid hormones. So cortisol is a steroid from the adrenal cortex, aldosterone as well, estradiol, thyroid hormone. So water-soluble stays on the outside, lipid goes inside. Next, for question 14, I just want to illustrate the difference between sensitivity. And so the way to think about this is like a lover. If you're saying, hey, are you dating somebody else and they have to specify, then that is truly a negative trait. But if they're just a sensitive lover, that is truly a positive trait. And so you'll often see graphs like this, which will have somebody who's like a good normal population and somebody who's infected with some sort of a disease. And if you're trying to optimize for specificity and sensitivity, then you need to know how to manipulate where you're calling the shots. Are you calling it here, here, or here? We'll call these A, B, or C. And I have another video about this, so I'm not going to labor on this point. Specificity is truly a negative trait. And so if you need to be truly negative, it's going to be like right over here or C, because then you know that if you're negative, you are truly negative. So specificity and sensitivity are going to change based on where you call the shots. What is normal, what is healthy? And that's all I wanted to say about 14. So for this question, we have a 46-year-old man who has a history of renal transplantation on tacrolimus, developing reddish-purple nodule lesions on his anterior thigh and hard palate. He reports recent weight loss and non-productive cough. Bronchoscopy reveals endobronchioviolaceous nodules, and a biopsy of the skin lesion is obtained. Which histologic finding is most characteristic of the lesion? Okay, the violaceous stuff makes us think of HHV8, and that is Kaposi sarcoma. It's a vascular neoplasm. And the hallmark is going to be your spindle cell proliferation. So this is a very buzzy question. These lesions often involve the skin and mucosal sites and can also affect internal organs as well. So the answer is going to be your spindle cell, C. Why is it not the sheets though? So the sheets of atypical stuff with the starry sky is definitely going to be Burkitt's lymphoma. Starry sky, Burkitt's. Granulomas with giant cells, that's the hallmark of tuberculosis, not neoplastic at all. Keratin pearls, that's squamous cell carcinoma histology, not spindle. Polygonal cells with abundant cytoplasmic glycogen, that would be your clear cell carcinoma. So like renal, for instance, it's not going to be HHV8 driven. And what's really scary about this guy is that it's just a simple virus that transforms your blood vessels into tumors. So typically if you have a weakened immunity like those with HIV or post-transplant drugs, then you can get your human herpes virus 8 that hijacks your endothelial cells. And it'll drive them to just multiply abnormally, and they form these slit-like vascular channels that are packed with red blood cells. And this creates the violaceous plaques of Kaposi sarcoma on the skin, the mouth, and even deep in the lungs. So you're not going to see squamous stuff or any other kind of weird malignancies. It's just a violaceous plaques, immunosuppression, spindle cells is what you see. So purple lesions, and sometimes they can be just more than skin deep. So super scary Kaposi sarcoma. All right, here we have a 29-year-old woman hiking a mountain summit at 4,000 meters above the sea level. Within hours, she develops lightheadedness, tingling, confusion. What explains her arterial blood gas findings? So at high altitude, you have low atmospheric O2, and so you're going to stimulate your peripheral chemoreceptors to increase ventilation. So you have hyperventilation, and that causes excess CO2 excretion. So that CO2 is going to leave your body. CO2 is acidic, right? So it drives the bicarbonate buffer equation towards alkalosis. So you have acute respiratory alkalosis. And that's our answer C. Pretty simple. If there's impaired CO2 diffusion, that would cause retention of CO2. So you have respiratory acidosis. Ingestion of bicarbonate would cause metabolic alkalosis with a high bicarbonate, not a low PCO2. So that low PCO2 is really the dead giveaway. And that's kind of all I want to say about this one. In this next question, we have a 52-year-old man who was a carpenter presenting with persistent shoulder pain after weeks of overhead sanding work. He reports difficulty turning a doorknob outward. On exam, active abduction is full, but resisted external rotation produces a sharp pain. Passive range of motion is intact. Which structure is damaged? Answer is the infraspinatus. So the deficit here is the external rotation. So there's our infraspinatus, and that's going to be your external rotation. And that lies in the infraspinatus fossa below the scapular spine. And so you have atrophy in that region. It's going to further support chronic injury. So the other cuff muscles are going to have different functions. Like the supraspinatus would be abduction, internal rotation. And so the rotator cuff is just a team of 4 small muscles that stabilize and move the shoulder. Each has specialty. One lifts, one turns inward, and the other one goes outward. So if you see a patient who has pain and weakness only when turning the arm outward, then you got to think about which muscle does that. It's the infraspinatus, which sits just below the scapular spine, and is the external rotator. When it's injured or its nerve supply is compromised, then you lose the strength in the external rotation, and you'll often see a hollowed out appearance below the scapular spine. And on exams, you match the movement. The supraspinatus is going to be C5, C6. The infraspinatus as well, C5, C6. But you have the suprascapular nerve for those guys. And then the teres minor is also C5, C6, but the teres minor is axillary nerve. Subscapularis is C5 to C7. And that's the upper and lower subscapular nerves. And so you remember sits, supraspinatus. I'll write that down so you can sits, supraspinatus, infraspinatus, teres minor, subscapularis. So 2 share the suprascapular nerve, and 1 gets the axillary, and then the other gets the subscapular. Okay, that's it. Hope that sits well for you. Here we have a 55-year-old prison inmate. Already we're thinking about tuberculosis. Red rods, acid fast, yep. Which component is directly causing the macrophage injury? It's going to be your cord factor. So that's what opsonizes the bacteria and stimulates macrophage TNF-alpha release and directly damages your mitochondrial membranes, leading to the cytotoxicity. It's the secret weapon of tuberculosis. Teichoic acid, that's the gram-positive cell wall. And you can know it's teichoic acid because it has a T, and so it's positive. Endotoxins, the buzzword is lipopolysaccharide in the gram-negative sepsis. Capsule polysaccharide, that's anti-phagocytosis. It's not directly cytotoxic. Is going to be Neisseria species. So the lipo-oligosaccharide is the buzzword for Neisseria because Neisseria lacks a full-length O antigen on their outer membrane. And so instead of a lipopolysaccharide, they have a lipo-oligosaccharide. And it's a shorter variant. And these oligosaccharides, they're highly immunogenic, and it acts like an endotoxin. It triggers massive cytokine release and causes fever, hypotension, and also Waterhouse-Friderichsen syndrome. Saccharide is definitely your Neisseria. Lost. LOS. So I just wanted to show you this, some notes that I took. Okay, going back, we have a 27-year-old man presenting with high fever, chills, growing pain after 2 days of malaise. Lives in a region of Arizona, recently moved his fleas from his pet ferrets. 2-centimeter necrotic scar on his thigh, and a tender, fluctuant 4x4 centimeter mass in the inguinal region. Stain shows gram-neg. Okay, so that's making us think of Yersinia for sure. So Bartonella, maybe like a cat scratch problem, produces small papules and mild lymphadenopathy, not hemorrhagic pneumonia. So our answer is indeed B for this one. That's rapid cellulitis after a cat or a dog bite. You wouldn't see the buboes, like the bubonic plague. These rickets, that's Rocky Mountain spotted fever. So you have a rash with tick exposure, not and Bruce. That's the undulant fever from unpasteurized dairy is Brucella. It's not like a flea vector from the fleas and your ferrets. So yeah, this guy's transmitted by your rodents. And this obviously changed human history. Bubonic plague. Ever heard of her? Yersinia pestis. Enters through the skin, creates a necrotic ulcer, travels to nearby lymph nodes, and the lymph nodes swell into painful buboes that are packed with bacteria. If they're untreated, then the infection spills out into the bloodstream and the lungs and it causes sepsis and hemorrhagic pneumonia. And so you see flea exposure, skin eschar, and tender bubo with a gram-negative coccobacilli, then it's Yersinia. Pasteurella just gives cellulitis. Bartonella is cat scratch, which again we covered in this video, is inflammation to the subcutaneous connective tissue. Ulcers, buboes, pneumonia is going to be the plague. I've got the plague, sir. Okay, 420, we have a 42-year-old man who's got 10 days of tingling around his mouth and painful head cramps. He had a thyroidectomy 2 weeks ago for toxic molten goiter. He only takes levothyroxine. And we got prolonged QT, which best explains these symptoms, that problem. It's going to be decreased secretion of parathyroid hormone. And so you always are going to connect the recent neck injury with a hypocalcemic symptom. Hyper would be bones, stones, psychiatric overtones. And the big thing here is you just got to think about where the parathyroid glands sit. It's right behind the thyroid. And so they're super small. And so during surgery, they can be accidentally removed or lose their blood supply. And those glands make parathyroid hormone, which keeps your calcium levels normal. So less PTH, less calcium is pulled from the bones, and less calcium is kept by the kidneys. You will get to your tingling around the mouth and the fingers, and also muscle twitching, and you can also have laryngeal spasms. You have prolonged QT because the low calcium affects the heart repolarization as well. Okay, the next question, we have a 65-year-old woman who's got poorly controlled hypertension and recurrent flash pulmonary edema, undergoes endovascular evaluation for suspected renovascular disease. A cath is introduced via the right femoral artery and advanced through the external and common iliac arteries into the abdominal aorta. To engage with the left renal artery, they must position the cath tip just superior to the origin of what? So the kidneys get about 20% of your entire cardiac output. And when interventionalists go through the femoral artery to fix the problem, they're essentially traveling upstream, the external iliac, the common iliac, and then the aorta. So the renal arteries branch off the aorta around L1, L2. And just below them come the paired gonadal arteries. So you can kind of see this illustration right here. So to safely enter a renal artery with this catheter, you advance the tip until it's positioned just above those gonadal branches. And both the right and left gonadal arteries, so testicular in men, ovarian in women, also branch from the abdominal aorta, just inferior to their renal arteries. The only difference is between the right and the left is their course. So the right renal artery is longer because it has to pass behind the inferior vena cava to reach the right kidney. See that inferior vena cava? See that right kidney? Renal artery. So the arteries, because this is commonly confused, both the right and the left branch off the aorta at L1, L2. But the veins have your different sides. The left renal vein is much longer because it crosses in front of the aorta to reach the IVC. And it collects blood from the left adrenal vein and the left gonadal vein before it drains. The right renal vein is shorter and it drains directly into the IVC without those tributaries. The right testicular vein drains directly to the IVC. So arterial access to either renal artery, the catheter should be positioned in the abdominal aorta just superior to the origin of the gonadal arteries. So left renal vein, long, crosses in front of the aorta, receives left adrenal vein, and that's why left side varices are common, and the right is shorter, drains directly into the IVC. Okay, our next practice question. Here we have a 24-year-old woman sustains a deep laceration of her left forearm while rock climbing. The wound is sutured and initially filled with granulation tissue. 6 months later, her scar is flat, pale, much stronger. What's responsible for it? Matrix metalloproteinase. So these enzymes allow the replacement of weaker type 3 collagen with type 1 collagen, which increases the tensile strength. Matrix metalloproteinases, they're a family of zinc-dependent endopeptidases that degrade components of the extracellular matrix. They're commonly secreted as inactive proenzymes, and they're activated locally when the remodeling is needed. So with scar remodeling, what happens is we break down the immature extracellular matrix. Osteoclasts and chondroclasts use MMPs to reabsorb bone and cartilage. Pathologically, you can also see there's tumor invasion and metastasis that use these guys to degrade the basement membranes and the surrounding stroma. So they're produced by the fibroblasts, macrophages, neutrophils, and some of the epithelial cells, and they're controlled by tissue inhibitors of metalloproteinases, which are called TIMPs, and it prevents the excess tissue destruction. So when you're wound healing, you have granulation tissue that forms with your type 3 collagen, and then the type 1 collagen is deposited, and you get a scar that's stronger over the months. And so zinc is a key cofactor. A deficiency there would cause poor wound healing, so that's why you need zinc. Overactivity is implicated in the tumor metastasis and also chronic ulcers. So watch out for those tumors and those ulcers, and underactivity leads to excessive scar tissue and keloid formation. Next question, we have a 46-year-old woman. She's got trauma, undergoes creation of a arteriovenous fistula in her forearm for dialysis access. 5 seconds after the fistula is unclamped, she develops bounding radial pulses and a thrill over the site. On a cardiac function curve plotting the right atrial pressure against the cardiac output, which point would represent her hemodynamics immediately after the fistula is opened. So the fistula creates a low resistance pathway that causes a sudden increase in the venous return, which is the preload. And a normal heart responds to the Frank-Starling mechanisms, generating higher cardiac output, while the right atrial pressure also rises from the increased flow. Basically, you open a large arteriovenous fistula, and in seconds, the blood just gushes from the high pressure artery straight into the low resistance vein. And that sudden surge is going to just rocket that venous return straight to the heart. And so the heart, if it's normal, responds instantly with the Frank-Starling mechanism. So more preload, what does that mean? More pumping. The cardiac output will then climb, and then the right atrial pressure also goes way up because of that high volume return. And so on cardiac function curves, you're not going to see like any baseline stuff. You'd be jumping to a point where there's higher cardiac output and higher right atrial pressure because there's more blood flowing, and so you got to pump more to keep up. It's the Frank-Starling mechanism. And that's why the answer is D, higher cardiac output and higher right atrial pressure. Next, we got a 54-year-old woman with a known cirrhosis that presents with progressive dyspnea. The right lung base has breath sounds that are absent, dull percussion, and the left lung has a normal exam. What's going to explain these findings? It's going to be a pleural effusion. And here is the explanation and the reasons why. So a single liter of fluid in the pleural space can almost silence an entire lung base. Just 1 liter. So when the fluids build up between the lung and the chest wall, vibrations can't travel through it. And that's why on exam you hear the diminished absent breath sounds. You also feel the decreased tactile fremitus, and the percussion sounds are going to be dull. Low-bar pneumonia, increased fremitus. That's because of the consolidated lung, and low-bar ammonia transmits better. Pulmonary embolism, it'd be normal, no dullness. Tension gives hyperresonance. Chronic bronchitis, diffuse wheezes, unilateral dullness. Okay, so we have a 69-year-old retired construction worker who brings his 68-year-old sister to her clinic visit. She has a vertebral compression fracture from osteoporosis, and he says they both smoked in youth, ate the same family males, yet she has the brittle bones. What explains this? Men build a more massive skeletal framework during growth. And the reason for this is testosterone. So you get wider and more dense bones by early adulthood, and even as you have age-related resorption, which they're both undergoing, the greater initial bone stock delays or prevents reaching the osteoporotic threshold. So it's really that early massive skeletal framework that the men have that the women don't. The sex steroids modulate the osteoblasts and osteoclasts differently. In puberty, the male skeletons expand in width beyond their female counterparts. They both lose bone, but the women experience a sharp decline post-menopause. It's all about that androgen-driven bone remodeling during puberty and a menopause-related hormone drop, which favors the osteoclast, causing osteoporosis. All right, here we go, filling it up. Be sure to like and subscribe, but only if you found that this takes tons of time and I'm doing it for you. Hello, everyone. We're back. These videos take days to make, and today we are doing 26 through 50. Please like and subscribe, especially if you appreciate the work we're doing here. So question 26, we have a 42-year-old woman with a history of sclerodoma, presenting with progressive heartburn and chronic cough, especially at night. She's tried over-the-counter antacids with minimal relief. Endoscopy reveals erythematous mucosa with small erosions of the distal esophagus. Ooh, they're giving something that inhibits the membrane pump in the gastric parietal cells. What are they going to give her? Probably Prazole. Yep, there's the answer, Prazole. So the big buzzwords, if you will, for 26 are going to be, you have to know that PPIs function by irreversible inhibition. These hydrogen potassium ATPase pumps, these are proton pump inhibitors. They covalently bind to the sulfohydryl groups on the proton pump, and it shuts it down until the new pump can be synthesized. There are several pathways to acid secretion, and PPIs block that final pathway for acid secretion regardless of the upstream signaling. Histamine upstream, or your gastrin upstream, or the commonly forgot about acetylcholine. All that is upstream, and then here is our PPI. And so these guys are the terminator. They say, nope. Some associations you need to know about these PPIs are Barrett's esophagus, that's intestinal metaplasia due to the chronic reflux. You have constant acid injury, and that'll stimulate the columnar metaplasia. Also, chronic PPI use increases your risk for C. diff, and it also decreases your magnesium. That's because hypochlorhydria alters the gut flora and magnesium absorption. The pathophys here is that the parietal cells pump the hydrogen into the lumen through these pumps. So we got that hydrogen into the lumen, and then GERD involves the lower esophageal dysfunction. You get acid reflux and esophageal irritation, and that's potential metaplasia. The PPI irreversibly inactivates that pump, and you have profound acid suppression. And then you get mucosal healing. PPIs, you think like omeprazole, esomeprazole, pantoprazole, and these must be taken before the meals. Long term, you're going to monitor for your B12 deficiency, and the gold standard for the treatment of your erosive esophagitis and also Zollinger-Ellison syndrome is a PPI. So on test day, you might see, there's a man or a woman with a 6-month history of nocturnal chest pain and sour tasting in the mouth. Symptoms are worsening after dinners or when lying flat. Endoscopy can show some linear erosions of the distal esophagus. You got to give them that old omeprazole. It's first-line therapy for symptomatic GERD with erosive changes. Now, what you have to look out for, though, with other topics would be like an answer choice could be ranitidine, and that is a histamine 2 blocker, kind of like how we talked about there are other things upstream. That's reversible. It's less potent. It might also give you some other options like misoprostol, which is a prostaglandin analog, and that protects the NSAID-induced ulcers. It's not going to be first line for GERD, so not that. Bismuth, that coats the ulcers and it kills H. pylori. There's no pump inhibition, so that could be an answer, but that's just coating. Sucralfate, that forms your protective barrier in the acidic environment. Now, you might be wondering, okay, why does chronic PPI use increase C. diff? And hypomagnesemia risk is seen in the small intestine requires a favorable pH in active transporters. And so chronic hypochlorhydria from your PPI use, hypochlorhydria, will lead to reduced solubilization of the dietary magnesium salts. So there's less bioavailable magnesium. So just note those two things as well, and you should be good to go on PPIs. Next is our question 27. So here we have a 48-year-old man with metabolic syndrome and started on rosiglitazone for hyperglycemia and fenofibrate for severe triglyceridemia. Both medications exert their therapeutic effects by binding which receptor? Now, they made it pretty easy by giving us 2 medications, but it's going to be our PPARs. These are nuclear transcription factors. So your glitazones, they activate your PPAR gamma. I'll write that down. And that will enhance your insulin sensitivity. And then fibrates, like fenofibrate, activate your PPAR alpha. And these glitazones are your diones. Really hard to say, but the glitazones, they activate that PPAR Y, because they want to have a glittery party. That's the way I like to think of it. Whereas these guys, fibrates with the A's, like to activate the A, the alpha. And they're going to upregulate your lipoprotein lipase to lower your triglyceride levels, and both require gene transcription to achieve their effects. All right, epidermal growth factor receptors, that's not the right answer, because that's cell growth signaling. That's not involved in that's involved in oncogenesis, not metabolic modulation. Farnesoid X receptors, these are bile acid synthesis regulators. They control the cholesterol catabolism, and it's unrelated to insulin or fibrates. Correct answer is C. Toll-like receptors. These guys are innate immune pathogen sensors. They trigger your F-kappa B your cytokines. They're not lipid or glucose metabolism associated. And your dopamine receptors, totally different. Neurotransmission modulation is what they're used for. They are targeted by antipsychotics and also antiemetics, so they're totally relevant there. So basically what you need to know for this one is that some diabetes drugs and cholesterol drugs actually work on the exact same receptor. Though thiazodinodiones like pioglitazone and fibrates like gemfibrozil both target the PPAR. So they're nuclear receptors that turn the genes on and off. And when these receptors are activated, your cells change how they handle sugar and fats. And so PPAR gamma activation improves insulin sensitivity. And PPAR alpha activation boosts your lipoprotein lipase, which clears your triglyceride. So you say goodbye to those triglycerides. Okay, so just knowing the mechanism of action is sufficient for answering this question. All right, so our next question, we have a 36-year-old man with a spinal cord injury is admitted after traffic accident. 4 hours later, the nursing staff notes that he has developed a rigid, painful penile erection despite no stimulation. His temperature is normal and his blood pressure is 118, so he's not taking any medications, and neurological exam shows a loss of voluntary movement below the T10 levels. Okay, what is impaired leading to this problem? And so this is going to require your sympathetic fibers to release norepinephrine and constrict the arteries of the corpus cavernosa. So in a spinal cord injury with the PDE5 inhibitors, the sympathetic input is lost or overridden. And that causes this condition, which is known as priapism. Okay, so what is impaired? It's not the parasympathetics. These are the initiators of that erection. So increased vasodilation, it's not responsible for the alleviation of this condition here. General sensory, tactile input only provides your sensory feedback, not your vascular tone. Somatic motor, so the perineal muscle contraction is associated with your somatic motor fibers. So that could help with the rigidity, but going to be a separate mechanism. And then E, visceral afferents, these stretch and give pelvic organ feedback, and it's unrelated to your vascular control. A single nerve pathway can decide whether this man's erections will end or continue. So normally your sympathetic fibers from the pelvic plexus are going to fire off norepinephrine to clamp down on the blood vessels. And that's what makes the erection go away. When these sympathetic signals are lost, like a spinal cord injury or overridden by drugs like sildenafil, then the blood keeps pooling and the result is priapism. So it's painful and it lasts several hours. And so in this question, we got a dude with a spinal cord injury and he has that persistent erection without stimulation. So the neural pathway that's damaged at the sympathetic fibers from the hypogastric and the prostatic plexus that normally shut the things down. And so the way you remember this is the point. The P stands for your parasympathetic because the erection is parasympathetic, but D-tumescence is sympathetic. And when the sympathetic input is missing, then it's not going to stop. And so that's high yield neuroanatomy. For 29, we got a study that follows patients diagnosed with pancreatic, prostate, and renal cell carcinoma. What's the most accurate prediction of this data? The answer is a 5-year mortality after renal cell carcinoma is higher than after prostate cancer. What you need to know for this is that mortality equals 1 minus the survival population proportion. Renal cell is 0.7, so the mortality is 0.3, and pancreatic has a mortality rate of 0.95. And that means that after 5-year mortality after renal cell is higher than prostate is a correct statement, and that's why it's the correct answer. Okay, next we have a researcher studying cardiac fibroblasts exposed to medium rich in advanced glycosylation and end products versus the control medium. After 48 hours, she isolates mRNA to measure the expression of genes involved in extracellular remodeling. Which of the following mRNA species would most likely be increased in AGE-treated fibroblasts compared to the controls? Okay, so advanced glycosylation end products, AGE, stimulate mesangial cells to overproduce extracellular matrix. And fibronectin is a key extracellular matrix glycoprotein, and it would show an increased mRNA expression under these stimulations. Fibronectin deposition in diabetic nephropathy is driven by AGE-mediated signaling that enhances the ECM production. Extracellular matrix is ECM, by the way. So mesangial expansion occurs because of that excessive ECM, proteins like fibronectin and also collagen. And the associations you need to know for this question are diabetic nephropathy, chronic hyperglycemia that leads to AGE accumulation in the mesangium that stimulates your TGF-beta in the ECM stimulus or your synthesis. Fibromectin integration interactions, they mediate the cell adhesion and branching of the matrix formation in the glomeruli. And so basically what's happening is we have high glucose in our dude that causes non-enzymatic glycation and to get AGEs on the basement membrane and the extracellular matrix. And these AGEs bind receptors on mesangial cells and they activate intracellular signaling through the TGF-beta pathway. And then the upregulation of genes that encode for the extracellular matrix protein, like fibronectin and collagen, cause mesangial expansion and glomerular sclerosis. So fibronectin, you just need to know that it's involved in cell adhesion, cell migration, and tissue organization. We have increased mRNA for fibronectin. That's a hallmark of ECM production. And mesangial proliferation and thickening is seen in diabetic kidney disease, and that leads to reduced filtration surface area and progressive nephropathy. So just to make this super duper simple, because I know that a lot of these topics are kind of lower yield, AGEs from high sugar make the kidney mesangial cells produce extracellular matrix, and that's what you need to know. And fibronectin is just one of those main matrix proteins. That's it. So AGEs trigger the cells to lay down more fibronectin, and diabetic nephropathy is thickened glomeruli from the extracellular matrix. This is seen commonly in chronic diabetics because AGEs build up and activate those cells, and it leads to glomerular sclerosis, which is the scarring of the kidney filters. And so high sugar means the AGEs are going to form, and AGE signaling mesangial cells causes more fibronectin, more thick basement membrane deposition. All right, why not vascular endothelial growth factor? That's involved in angiogenesis, so that's not it. Why not inducible nitric oxide synthase? Well, that wouldn't produce your matrix proteins, that would produce nitric oxide, so it's a vasodilator. NADPH oxidase. Answers would be about oxidative burst or something like catalase positive organisms infecting you. Caspase 3, this is the executioner of apoptosis, so it's going to be unrelated as well, so fibronectin is the best answer choice. Okay, moving on in the world. Now, for this one, I'm going to flex my beautiful drawing abilities. Wow, I tried and it deleted some of it, and then I didn't want to do it again. This, if you could see, is the world's worst drawing of the cerebellar vermis. Yeah, that's really, really bad. You know what? We don't have to see that. Okay, I just redrew it. Just kidding. But yeah, no, this is the cerebellar vermis. It controls motor function and axial and proximal limb coordination. Truncal instability and gait ataxia would be seen if you have lesions. The midline would cause wide-based unsteady gait. Alcoholic cerebellar degeneration would cause truncal ataxia. So chronic alcoholism can literally shrink part of your cerebellum. And when the cerebellar vermis wastes away, then the patients lose their ability to control their posture and balance. And the vermis sits on the midline of the cerebellum and it directs the trunk and the proximal limb muscles. Damage there does not mess up your finger to nose test, but it does make you sway and stumble when you walk. You'll see a patient with vermian atrophy and wide-based unsteady gait, then it's going to be clinically diagnosed as gait ataxia with truncal instability. And so the midline cerebellum causes that axial control. And you lose it and the patients can't walk straight no matter how strong their legs are. So in this practice question, which neurological finding? It's gait ataxia with truncal instability. Question 33, a 6-month-old infant is brought to the emergency department with poor feeding, generalized weakness, and decreased spontaneous movements. The parents report giving the infant honey. Neurological examination says hypotonia and diminished reflexes. Nerve conduction studies are normal, and a muscle biopsy is tested under reduced extracellular calcium to prevent action potentials. Compared to healthy controls, what do you expect to see? Answer B. So just a teaspoon of honey is enough to paralyze a baby. In infant botulism, the spores germinate in the gut and they release toxins, and this blocks acetylcholine release at the neuromuscular junction. It's all about blocking that acetylcholine release. And so if we test this in a lab, then we'll see the end plate potential shrinks because there are fewer vesicles that release acetylcholine, but those tiny spontaneous miniature potentials are normal. And so if you drip acetylcholine directly on the muscle, then the response is going to be perfectly normal. For our baby with floppy tone after honey ingestion, the pattern is going to be low end plate potential, normal MEPP, and normal acetylcholine receptors. Basically, it's a way of saying that we know the motor neuron action potential reaches the terminal, and normally the calcium influx triggers the snare-mediated vesicle fusion, and then it causes acetylcholine release and end plate potential. But botulinum toxin destroys the snare, and so you have no vesicles being released. I should probably write that down. The snare protein destroyed. And so there's no vesicle release, and so the end plate potential has a decreased amplitude. But the receptor and everything else is just going to be totally fine. It's just that you don't have a lot of acetylcholine going on there. Everything else is just going to be totally normal. But the end plate potential is going to be decreased. In our next question, we're going to be talking about dysdiadochokinesia, impaired rapid alternating movements, and it's a sign of cerebellar dysfunction. Here's our question and answer. We have a 10-year-old boy evaluated for 1 week of unsteady gait, morning headaches, neurological examination reveals nystagmus, and difficulty walking in a straight line. So he's got nystagmus, the rapidly alternating eyes, and difficulty walking in a straight line. The mom asks if there's a quick bedside maneuver that would help confirm involvement of the cerebellum. What would strongly argue against cerebellar tumor? Well, if there's a cerebellar tumor, then you're going to have problems with your movement, especially the rapid alternating movements. So the answer is C. Because the cerebellum does fine-tuned motor movement, so you have the inability to switch rapidly between opposite movements. You'll tell them, hey, kid, can you flip your hands back and forth quickly? And the cerebellum will cause the smooth muscles to move in that formation. And so if it's damaged, then the child can't alternate rapidly, and that's his condition. All right, Babinski is a corticospinal tract lesion sign. It's unrelated to the cerebellum. The doll's eyes reflex the brainstem integrity test. It's not specific to the cerebellum, so don't worry about it. Retinal sign, that's the median nerve irritation, so it's peripheral neuropathy associated, not cerebellum. The glabellar is when you tap their forehead, and it should cause blinking. All right, next we have 45-year-old woman, 25-year pack history of smoking, says, I know smoking isn't great, but I don't think I can quit right now. The physician wants to use motivational interviewing to guide her. What are you going to do? You're just going to ask open-ended questions. What makes you feel like it's not the right time? Okay, so my biggest advice in this section is open-ended. Keep it open-ended, keep it autonomous, and you should be good to go with your ethics questions. Help them unlock their own motivation. Okay, some things to look out for. Don't be cost-focused. Don't use guilt. Don't educate too early. First, you have to assess if they want it and stuff. Don't be paternalistic or blaming. Next, we have a 48-year-old woman coming to our optometrist because she's noticed difficulty reading the menus. She has no trouble seeing distant objects, and her last eye exam was normal. And whoa, visual acuity is 20/20. Pupil's normal. Fundoscopic exam is normal, and she reads a near card only when holding it farther away. What's the diagnosis? So this is whenever you have a loss of accommodation for near vision with a preserved distance acuity for normal eye exams. Myopia is nearsightedness, so you can't see the far distances. Hyperopia is farsightedness from axial shortening, so that presents from childhood and affects both near and far. It's not isolated with near difficulty with a clear lens exam. And hypertensive retinopathy, that's the fundus changes. You'd see like arterial narrowing and hemorrhaging. And that's not the case here. By your mid-40s, almost everybody needs to hold reading material a bit farther away. And that's not a disease. It's farsightedness that's caused by a lack of the elasticity of the lens of the eye in middle and old age. So sad. Somebody's got to figure out antisenescence. Why are we still dying? So many sad age-related changes that aren't going to be a thing in the next 100 years. But I digress. 37. Okay, so here we're going to talk about gastrinomas and how they secrete the excess gastrin, and they drive parietal cells to secrete hydrogen ions. So you get that juicy HCl. And the parietal cells are large cells in the middle of the gastric glands with central nucleus. So if you see large eosinophilic cytoplasm with central nucleus, it's going to be parietal cell. And Zollinger-Ellison syndrome is a gastrin-secreting tumor that causes recurrent ulcers. The associations are MEN1, think of the 3 Ps, pancreatic, pituitary, parathyroid, excess acid malabsorption, causing duodenal enzymes that are activated by low pH, or inactivated rather by low pH. Because you have way too much acid, and so you're not going to be able to activate these enzymes anymore. It's too acidic. They ain't going to touch that. Acid hypersecretion causes peptic ulcers beyond the duodenal bulb. So in our practice question, we have a 48-year-old man, recurrent gastric pain, diarrhea, multiple duodenal ulcers despite PPIs. Which labeled cell is being excessively stimulated? This is the mucous neck cell. Spoiler alert, no it is not. That's pale cytoplasm. And I've just given you our little histological slide, but you don't really need it. Chief cells are basophilic pepsinogen secreting, so they digest the protein, not the acid. Endothelial cells, these guys line the capillaries. There's no secretory function for the acid. So no, not your endothelials. That's silly. Fibroblasts. These guys are connective tissues. So they make the extracellular matrix, not gastric acid, right? So a tiny, tiny tumor in the pancreas or the duodenum can turn your stomach into an acid-making factory. That is the Ehlers-Danlos syndrome, where a gastronoma pumps out excessive, massive amounts of gastrin. It'll travel to the stomach and overstimulate the parietal cells. And they're the pink acid-making cells in the gastric glands. And these cells unleash hydrogen ions nonstop. It's like their favorite thing to do. They're just like, ooh, ooh, hydrogen, ooh, yeah. Just unleashing them, creating ulcers everywhere that don't heal. And they even cause diarrhea from enzyme inactivation. When you're asked about the cell that's overstimulated to secrete the acid in this scenario, the answer is going to be the parietal cell. And I have drawn this most beautiful, beautiful histological slide. That's a joke, by the way. Here's our next question and answer duo. We got a 64-year-old right-handed man is brought to the emergency department after sudden onset of the right facial droop and inability to speak. He shows a large hypodense area involving the lateral surface of the left frontal and temporal lobes. Which of the following neurological findings is most likely? So here we have a dominant, usually left, MCA. Infarct is going to affect both the and Wernicke's areas, and that disrupts the speech production and the comprehension. So that's global aphasia. Additional deficits like your right face or arm weakness can also coexist, but the language dysfunction is really the hallmark, and so it's going to be of that MCA stroke. And so left hemiparesis, so the answer is A, but B, the right hemisphere lesion, that's not going to be seen in your MCA infarct. Spatial neglect, that's the non-dominant parietal lobe, typically in right MCA infarcts. Right facial paralysis involving the forehead and the jaw muscles. So lower motor neuron lesion of cranial nerve 7, it's not going to be cortical. Weakness of lower face on the left side only. So the upper motor neuron lesion on the contralateral side would spare the language centers. There's one artery that supplies most of your speech centers, and that's the middle cerebral. And it feeds the Broca's area for language production and Wernicke's for comprehension. If you get a clot that blocks your MCA in a right-handed person, then both regions can be knocked out at once, and the result is global aphasia. So the speech is non-fluent, comprehension is impaired. And so here we have like a CT scan. On test day, you might see something like a left MCA infarct with language deficits, and it's most likely going to be global aphasia. All right, next on test day, if you see a 29-year-old African-American woman, you should probably just click granulomas and call it a day, not going to lie. But blurry vision, dry eyes, fatigue, we got some bumps in the shins, all that good stuff. This is just going to be hallmark sarcoidosis. It is really important to notice that it's African-American female who shows up with dry eyes, uveitis, tender shin nodules, and the chest x-ray is going to be bright with bilateral hilar lymph nodes. That's just going to be sarcoidosis. It's one of the most pathognomonic conditions on all of step 1. And so these lymph nodes are going to be packed with non-caseating granulomas, tight clusters of epithelioid histiocytes and giant cells, but no central necrosis. And so just like super pathognomonic finding is non-caseating granulomas, textbook sarcoidosis. Not much else to say about this guy. Now you might be thinking, okay, what about the shins and sarcoidosis? So one of the classic skin findings is going to be erythema nodosum, and that's the tender red violaceous nodules on the anterior shins that are caused by inflammation of the subcutaneous fat, paniculitis. So the anterior tibial region has a lot of subcutaneous fat, and it's prone to immune-mediated paniculitis reaction. Sarcoidosis is a T-cell driven inflammation that leads to septal paniculitis without vasculitis, and so presents as erythema nodosa. So bilateral highly lymphadenopathy, erythema nodosum, all that good stuff. Let's look at the other answer choices. Abscess with case, that's tuberculosis. Reed-Sternberg is Hodgkin's. Langerhans is histiocytes. Could be bone and skin in children, not the lungs and the eyes. Metastatic adeno is gland forming. Now, for 40, I'm going to do something a little bit different. I'm going to tell you everything you need to know that'll give away selection bias on step 1. If you see internet or ad surveys, like flyers, newspaper ads, then you got to think of self-selection bias. And then there are different types of bias you got to know. Non-response, those who respond are usually healthier. Berkson bias, it's when you sample just from hospitals. Healthy workers, when you study only employed individuals. Prevalence, incidence bias, that's when you have low-risk patients that receive certain therapies. Surveillance bias is when one is monitored more closely, and so it's more likely you'll find a disease because you're looking at them more. And then referral patients are not representative of the general population because they're at specialized centers, so they're more severe cases. And there's a big old list of all of them. Okay, here we get to talk about pseudopodia for 41. So here are the temporary projections of the cell used for locomotion and phagocytosis. Check it out. Look at this. Now let's do this question. Researchers study a new compound that disrupts actin filament polymerization in neutrophils. After the treatment, the cells show normal receptor binding and normal uptake, but they fail to ingest opsonized bacteria, which leukocyte function is most likely impaired. The answer is phagocytosis, surprisingly. So actin polymerization drives the physical engulfment of and binding events, and small-scale endocytosis like pinocytosis and clathrin-mediated uptake can still occur without the extensive actin remodeling. So if you would, imagine we have a neutrophil and he's chasing down bacteria. To swallow that little microbe, it has to reshape its membrane into a cup and it has to wrap around the invader. Nom 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 nom. And that reshaping is powered by actin filaments that push the membrane forward. And if you block the actin polymerization, then the cell cannot extend its arms. It can still sip fluid through pinocytosis, but it can't engulf any bacteria. And so in our question, the function most impaired by the actin blocking drug is phagocytosis. 42, what a good number. 14-month-old boy is evaluated for delayed milestones. His parents note that he's become less interactive and has joint stiffness. Exam shows hepatosplenomegaly, coarse facial features, and bilateral corneal clouding. And there's elevated dermatan sulfates and heparin. So this one is just like a memorization one. We have to know it's alpha L iduronidase. This is Hurler's. It's not Hunter's because corneal. You need the cornea. So the corneal clouding is just Hurler's. It's probably good to dissect each of these and know what they are. So beta saminidase is Tay disease. You have a cherry red macula, and there's no hepatosplenomegaly there. L-sulfatase A, metachromatic leukodystrophy, that's demyelination, ataxia, not corneal clouding. Glucose 6 phosphatase, that's von Gierk's disease. You have hypoglycemia, not glycosamine storage. And sphingomyelinase, that would be Niemann-Pick. You have cherry red spot with hepatosplenomegaly. But there's no corneal clouding as a dead giveaway with your dermatan sulfate and heparins for this guy, B. Okay, we're going to name the arches. See how well we know these guys. First is the pharyngeal arch, that's the mandibular arch. Our cartilage derivatives are Meikle's cartilage, so you have the mandible, malleus, sphenomandibular ligament. And you have the muscles, like the muscles of mastication, the masseter temporalis, medial lateral pterygoids, mylohyoid, anterior belly of the digastric, and all that stuff. And the nerve is going to be 5-3, cranial nerve 5-3, mandibular division of the trigeminal. And so clinically, you have Pierre-Robinson sequence, that's Crognathia, glossoptosis, and cleft palate. Also, you can have the Treacher-Collins syndrome, which is mandibulofacial dysostosis. With one, we should be thinking of PA, Treacher-Collins. And then with the second pharyngeal arch, this is the hyoid arch. The cartilage derivatives are going to lead to your stapes, styloid process, hyoid ligament, lesser horn, upper body of the hyoid. The muscles will be the muscles of facial expression, stapedius, stylohyoid, posterior belly of digastric. The nerve is cranial nerve 7. Facial nerve. And here you'll see the facial palsy syndromes like congenital stapes fixation leading to the conductive hearing loss. For your third arch, the cartilage derivatives lead to the greater horn and the lower body of the hyoid. Here's the stylopharyngeus, cranial nerve 9, which is going to be your glossopharyngeal nerve. Pharyngeal constrictors, and the nerve is going to be the superior laryngeal branch of the cranial nerve 10. So the defects can affect the swallowing and the pitch controls. The cricothyroid has the tense vocal cords. And the fourth is going to be the thyroid cartilage parts and some of the laryngeal structures as well, like cricolevator veli palantini. And then our sixth is the cricoid, all the intrinsic muscles of the larynx except the cricothyroid, and also the recurrent laryngeal branch of cranial nerve 10. So the defects are going to be vocal cord paralysis, hoarseness, and stridor, number 6. And they like to test this one. So 1, mastication. Think of the M structures like Meckel, mandible, mastication. 2 is the smile, so the facial expressions. 3 is the swallow. I think swallow stylishly is the mnemonic there. Stylopharyngeus is 3. Then 4 is the simple swallow, the pharyngeal constrictors. And then 6 is speaking, so the intrinsic laryngeal muscles. So you think masticate, smile, swallow stylishly, simply swallow, and speak. That's the way to think about it. 1, mastication. 2, smile. 3, swallow stylishly. 4 is a simple swallow. And then 6 is speak free. That's what we used to say in the camp back in the day. 44, 52-year-old woman undergoes surgery and suspected of right ovarian carcinoma. Surgeon plans to perform a lymph node dissection of the ovary's primary lymphatic drainage. Where are these nodes located? Answers along the ovarian vessels. And now these lymph drainage stuff, these questions can be a little bit complicated. So ovaries don't drain where you think. They develop high in the abdomen, and so they carry their blood supply and lymphatics down as far as they descend. And those lymphatics run with the ovarian artery and the vein inside of the suspensory ligament. And their first stop is the periaortic lymph nodes that sit along those vessels. And so in this question, when the ovarian tumor spreads, the first nodes to check are actually along the ovarian vessels. So the ovarians are going to be descending, and so it's not where you'd think they'd be. It's just along the ovarian vessels. Okay, why isn't it the broad ligament? So that's a peritoneal fold support, and it does not contain any primary lymph nodes whatsoever, just a support, not the answer. Lateral to the rectum, pararectal nodes, right? So those drain the rectum and the anal canal, not the ovaries. So nope. On the anterior surface of the sacrum, so that's the sacral nodes, they drain the pelvic organs, not the gonads. So pelvic organs, not the gonads, would be the anterior surface of the sacrum. Along the uterine fundus, that's not a lymph node bed at all. Uterine drainage also goes para-aortic, but the location is going to be just a little bit different. So yeah, they go along the vessels, and it's kind of good to think about how these ovaries get there in the first place, the migration pathway. So in this question, we have a 35-year-old woman developing severe abdominal pain and confusion 2 days after starting rifampin and for her latent tuberculosis. She has no rash or blistering. Urine collected during hospitalization turns dark. Labs show elevated aminolevulinic acid and porphobilinogen. Which enzyme is deficient? Porphobilinogen deaminase. Okay, so this one we need our big screen. We get a patient who starts a new medication, and within days she has crushing abdominal pain, hallucinations, and her urine is dark like burgundy wine. And this is going to be neurovisceral porphyria. And these porphyrias are just hereditary diseases in which the blood, pigment, and the hemoglobin is abnormally metabolized. So these porphyrins are excreted in the urine, which then becomes dark, and other symptoms are like mental disturbances and also extreme sensitivity to light. And so acute intermittent porphyria, it's a missing enzyme. And that missing enzyme is right here, step 3, porphobilinogen deaminase. That leads to a toxic buildup of the heme precursors, and these precursors irritate the nervous system, and then it causes some pain and psychiatric changes. But there's no skin blistering because the light-sensitive intermediates are never going to build up. And so in our question, the culprit is going to be porphobilinogen deaminase. Now, ALA synthase, this is the very first step, and this is going to be upregulated in this condition. ALA dehydratase, that leads to ALA buildup, but not porphobilinogen accumulation. And this is very kind of a rare form, is our step 2 form. Now, ferrochelatase, our step 7 right here, that's blocked in lead poisoning, and that causes protoporphyrin accumulation with photosensitivity. So lead, ferrochelatase deficiencies. There's also porphyria cutanea tarda. That's the uroporphyrinogen decarboxylase. So right around here, that would cause photosensitivity and skin fragility, not acute neurovisceral attacks like you'd see here. Porphobilinogen causes these defects that we see in this question. So it's acute intermittent porphyria, autosomal dominant disorder, and it's caused by these inactivating mutations in porphobilinogen. And here this can be seen with some episodes like ear psychosis. So watch out for that burgundy-colored urine. Okay, next we have a 6-year-old boy who's brought to the emergency department with 1-day history of severe right hip pain. He refuses to walk and cries when his leg is moved. Temperature is 102.7. Exam shows swollen, warm hip held in slight flexion and abduction. The lab reveals 33,000 and ESR of 110. What's the diagnosis? It's going to be septic arthritis. Septic arthritis overview for step 1. What is it? It's an infection of the joint space, so you have rapid joint destruction if it's untreated. The most common organisms in adults is going to be Staph aureus. It's the most common overall. And in sexually active young adults, it's Neisseria gonorrhea, so it's migratory polyarthritis. And prostatic joints, it's going to be Staph epidermidis. That's the biofilm stuff. The acute presentation is going to be acute monoarticular joint pain. You have swelling, warmth, erythema. Fever is also going to be present, and there's decreased range of motion, and the knee is going to be involved. So there's hematogenous spread of the bacteria in the synovial membrane. Also, there's neutrophil infiltration. We have a purulent exudate and the cartilage destruction within days if you don't treat it. Now, the diagnostic workup is definitely going to be atherocentesis is mandatory, and the synovial fluid is going to be turbid, purulent. The white blood cell count is greater than 50,000, mostly neutrophils typically. And of course, we do a gram stain so we can identify what it is. That's like the diagnostic workup flow. And atherocentesis is going to be joint aspiration. You use a needle and you withdraw the fluid from the joint for diagnostic or therapeutic purposes. So on test day, you will see a hot, swollen joint. So think of septic arthritis and first until proven otherwise. And also a purulent synovial fluid with high neutrophil count is very diagnostic for this. So typically you'll have like prostatic joints, rheumatoid arthritis, recent joint surgery, IV drug use, bacteremia, diabetes, things like that. And the treatment is in immediate IV antibiotics that target the Staph aureus, so like vancomycin, until you get the culture back. And then drainage of the infection joint as well. So gonococcal arthritis is often migratory, and non-gonococcal, like Staph aureus, is going to be more destructive and it's localized monoarthritis. So look out for those septic signs. Okay, 47. Let's do a difficult practice question. Investigators are designing a study comparing the renal concentrating ability of 3 groups. A, 25 to 30, B, 75 to 80, and then C is the same, but they're given an infusion of high-dose desmopressin, which is a synthetic ADH analog. Here are the results of urine osmolality? And the answer is decreased responsiveness of the collecting duct with aging, as aging progresses. And so you have lower urine osmolality in the older men compared to the younger men, especially when you're deprived of water. Okay, folks, almost there. Question 48. This is a really, really important question. Here we have a 6-year-old boy brought to the clinic for evaluation of swelling around his eyes and dark urine that he noticed in the morning. He has impetigo 3 weeks ago, 100-degree fever, 110/65. We have red-brown, so +3 in the blood and the urine, creatinine 1.8. Which of the following most likely diagnosis? Answer proliferative. So this kiddo had an infection, impetigo 3 weeks ago. So we had that bacterial infection a while back ago. And also now we have hematuria, red blood cell cast, and mild proteinuria and edema, and low C3 is going to be classic for proliferative glomerulonephritis, which is post-streptococcal. And now what you know is that PSGN is not at all different than proliferative glomerulonephritis. It's the same thing. It's a subtype of it. And so if you see a nephritic syndrome after somebody has a lumpy, bumpy deposit, then it's PSGN. And on histology, it'll show proliferative glomerulonephritis pattern. So PSGN is a cause of proliferative glomerulonephritis. If there's a kid, like a 6-year-old boy, who has an infection, then 2 weeks later he gets this, PSGN. Proliferative glomerulonephritis is the answer. Next, we're going to make this one super quick. Second to last question of this section. 10-year-old boy is brought in for patches of hair loss noticed over 2 weeks. Recently moved to a new city, started a new school. Exam shows 3 oddly shaped patches of alopecia, broken hairs of varying lengths. So the varying length tells you that he's pulling it out. Trichotillomania. So you're pulling out. We have irregular patches of alopecia with hairs of varying lengths and no inflammatory changes. So our answer is going to be C. For this one, we can distinguish between the other answer choices as well pretty easily, and I think that's important to do. So it's not alopecia, that'd be smooth patches with exclamation point hairs, not broken at varying lengths. So that's the reason why it's not A. Tinea capitis, that's going to be scaly patches with black dots and fungal infection signs, which are absent in this patient, so it's not going to be B. D, what the heck? I have no freaking idea what that is. Okay, apparently this is a form of temporary hair loss that's caused by disruption of the growth cycle. What in Sam Hale? Just temporary hair loss. Wow, you learn something new every day. I would not have chosen that anyway, though. So yeah, basically now we know it's not D. We're doing a quick Google search. But good night. I would never choose D as an answer just because on step 1, there's actually kind of a good teaching experience because on step 1, oftentimes you can just like pass this exam just by clicking what you're familiar with because this test is so buzzy and requires just like memory that you just know like one association for each of these terms, and that's usually enough to cross it off. Like E, secondary syphilis. For secondary syphilis is enough to be like, yeah, it's probably not going to be uneven hairs that are pulled. Whereas trichotillomania, when you're pulling the hairs, can be uneven, and that's enough to know. And so if they give you some weird off-the-wall, oddball question, because they totally will, by the way. On step 1, you totally are going to see like these just insane answer choices. Yeah, don't pick the ones that are buzzy, that are associated with something at least related to the question. Okay, last question. So as you can see, that last one generated with the help of some AI, and sometimes you encounter things you've never seen before. But here we are, the last question of NBME 27, section 1, that is. And also a long time to curate all of these questions and make them original. So please be sure to like and subscribe if you found this helpful. If not, comment how it can improve. Always trying to be better. So before we start, let's talk about the immune system real quick. So when the immune system senses infections, it's going to release IL-1, or rather that's going to turn on the NF-kappa B pathway, and that makes IL-6 and other inflammation mediators like fever and immune activation rush to the scene. Okay, so this is a pathway that's important to know. Kappa B from moving to the nucleus. But when IL-1 binds to the receptor, IL-1 binding activates the intracellular enzyme complex that's called I-kappa B kinase, or I-kappa K, and that phosphorylates this inhibitor. Yay, we phosphorylated that inhibitor. And then phosphorylating that I-kappa B makes it let go of the NF-kappa B, and it's then tagged for degradation. And now NF-kappa B is free, and it travels to the nucleus, and it turns on the genes for IL-6. Yay, we're going to go to the nucleus, and we're going to have a good old time banging out IL-6. And also many other pro-inflammatory proteins that aren't relevant to this question. But I-kappa B's job is to hold NF-kappa B inactive in the cytoplasm, just to hold it captive. It's kind of like if you guys ever played, like, capture the flag. You got like a prison over here, and I-kappa B is like the bodyguard. And then IL-1 is going to come over here and activate this pathway, distracting this bodyguard. So then this guy can go over to the nucleus and then do a jailbreak of the IL-6. If you guys had a good childhood, then that made sense. If not, then I'm sorry. Go outside and play capture the flag with your friends for once. So the key facts to remember is that if it has an I in it, it's probably an inhibitor. And there's also this kinase that phosphorylates the I-kappa B, which is the I-kappa K or the IKK. And then the IL-1 is the cytokine, the trigger that starts the whole entire cascade. Okay, cool. That's all I wanted to say. And now we have a 70-year-old man who's hospitalized for pneumonia. His fever is mediated by IL-6 after activation of the signaling in macrophages and resting macrophages. NF-kappa B is kept inactive by binding to a protein that must be phosphorylated and degraded so it can translate to the nucleus And the answer is going to be this one. Boom. I kappa B. So we said that NF kappa B is sequestered in the cytoplasm by this guy, the bodyguard. And upon stimulation, like IL-1, I kappa B is phosphorylated and degraded, and it frees it. So now NF kappa B is free to enter the nucleus, drive transcription. So then you get IL-6, which this dude now has the fever for because he's got the IL-6 going on in his blood. And folks, that is how it's done. We have just finished the first section of all of the questions that I believe are important for you to know by the time that you have finished your second NBME exam. So everybody be sure to like and subscribe if you found this content helpful. It'd be awesome to raise awareness of this channel. We're helping people prepare for step 1. Remember, all of this content is original, so go out there, take the tests, and then you can come here and you can learn all of the content. Make sure you do something fun today. For instance, like right now, I'm lifting some weights. It's how I relax, how I de-stress. Well, not really relax, but I don't know, keeps my mind active and off of the constant onslaught of medical content. Similarly, you guys should go out there and watch some movies. Do something fun with the rest of your day. If you have to study, you got to study, no big deal. Keep watching my playlist. But you know, life is so short, so go out there and do stuff that's fun. And if you're interested in this content, just like and subscribe. It really helps out the channel. All right, folks, that's all I wanted to say. Hopefully you guys have an amazing rest of your day. I've already heard back from a lot of people on this channel who have passed step 1 and really enjoyed it, and they've used the extension as well, so be sure to check that out. And like and subscribe for more content. We'll see you guys on the flippity flip.